abantu bambaza ngo ntabwo ngo ntacyo bari kumva, tell them twari tubategereje yuko you are admitted and tugakomeza. Okay, can you hear me then? Okay, ndabona musubiza bimeze neza. Okay, so nimara ko mutambwiye ko baje bose, baje se?
We may continue.
Yeah, I can continue.
Yes, but yes.
Okay. Okay, so ubu se ndamenya urumva ngo igihe natangira ntabwo bari bahari.
Ntabwo bari bahari.
Ubu se baje?
Twaje.
Ubu se ndasubira inyuma mana yanjye we. Ntiyataye. Ariko namwe nta kigenda nose mwe nimuza bakonekta bariho no mu kanya maje mumbwiye ngo subira buhagaze gato hari abandi bagiye kuza se.
Oya byatunganye. Ntabwo byongera ko byatunganye.
Ubu se nkomereze hariya subira inyuma mana yanjye.
Basubira aho inyuma ho gato.
Tangira kuri
inyuma gato.
Nyine technical. There are 5 things to interpreting.
Okay, ntacyo kambaye ka summary kihuta cyane. Okay.
Yes.
We said we are trying to see how chest X-ray is interpreted in radiology, and we say that we pass through 3 steps. And number 1 as a step is about identification of the film. By the way, it's the film, it's not the patient, because we don't even meet the patient. We just meet the film. It's identification of the patient. And in identification, we check the name, the date, the age of the patient, the view of the film, by the way, is it AP, is it PA, is it lateral, is it oblique, is it lateral decubitus, is it a lordotic view, and the date of examination. But a date, by just saying a date, but even time, because you can do multiple films, multiple X-rays for one patient. And I said identification is very important because you can just change your final diagnosis or differentials because of the gender, because of the age, you know. So you should consider that identification as something very important. The reason why the view comes into identification is when you are talking about film, you say, this is a PA film of the chest taken on this date of this patient, this age, male or something. You know, the view comes into identification. And here I explained to others different views we can make on chest radiograph. Because I say this is the first one is a PA view, posterior anterior view. Number 2 here, it's anterior posterior view when the film is coming, the X-ray beam coming from front, and the receiver, the cassette is behind. This is a lateral view to locate a disease. This is lateral decubitus to especially expand when you want to check if there is poor vision or not, a small poor vision or mild. And this AP view can be done while the patient is in neck position or in spine position, especially when the patient is very sick or ill. And the last one is a lordotic view, where the X-ray beam is no longer perpendicular to the body, but it is in oblique position. It is done when you want to see something that was not clear on the PA or AP view, okay? Especially when there is a lesion or an opacity under a rib or under the clavicle. So you do this view so that you can now remove that swine position of two things so that it becomes now clear. Okay. And number two, very, very important, even more than the third step, is about technical qualities of the film. Okay. By the way, let me jump this and go to the film like this one. Can you see the X-ray film image?
Yes.
Yes.
Can you see my slide?
Yes.
Yes.
And chest X-ray, can you see it?
Yes. Yes.
Okay. So I'm going to explain how we check technical qualities of the film using this film now. Number one, I told you have to check for is about centering or centeredness of the film or coordination of the film. It's when, how is it normal centering? It's well centered, let's say well centered. First of all, you should check if there's some soft tissue of the neck should be in for you to be sure that the apex of the film is there, it's in. And that's very important. You don't miss anything from the apex of the lungs. Number two, laterally, what you check for is about the joint, the shoulder joint. Normally, for you to be sure that the chest wall is within the film, because the chest wall should be in, you have to check if the shoulder joint are within the film. And inferiorly, you have to check if the costophrenic angles are within the film. They are not cut off. Okay? You don't Vikanyi? There you go. Aha. That you should, when you want to check the technical qualities of the film, number one, you have to start by it's that centeredness of the film. Number two, now other four, you can choose them and follow, give them another randomly. You can start by rotation or symmetry. You can start by penetration. You can start by deep inspiration or even angulation. Those are five. And number one is centering. Number two, symmetry or rotation. Number three is about penetration. Number four is deep inspiration. And number five is what you call angulation. Using this film, number two, because number one, we have seen it, how to check for it. Number two, let us take like a rotation, if there is symmetry or there is no rotation. I told you that these things are called spinous processes, and they are very well seen throughout the spine, especially the first thoracic ribs up there. So, you know, for everybody, they make a vertical line very well. And now, for you to know that there was no rotation, you have to check the distance between that line made by the spinous processes to the medial end of the clavicle. Like on the left side, the medial end of clavicle is this one. The distance from here to this line, and from here to the medial end of the clavicle on the right side, you try to estimate. It's about estimation. You don't use a ruler. It's estimation. You say they are almost the same. They are okay. There is no difference from those two different distances. So when they are almost the same, the distances, now you are sure that there was no rotation, it was symmetrical. Okay? And this is very important because if there was rotation, let me tell you, the anatomy of the chest is distorted completely. You can see a big part of the heart, for example, coming on the right side. And you even think of the extracardia as if it is abnormality, congenital abnormality. You can even see that, for example, a trachea that is not in the midline. It is deviated from the center. And you can say maybe there is a problem, or no, while really the issue was technical. Okay? That's number two. Number three is about penetration. The penetration is, how is it checked now? On the film like this one, you have to check the spine through the heart shadow. For penetration, a very well penetrated film, It's when you can see the spine, but not well. You see the spine through that shadow, but not well. You cannot talk much about the spine, but you can see it. You can see it faintly or just see it, you know. But when you see the spine through that shadow very well, you see the spine very well through that shadow, that is over penetration. And when there is over penetration, let me tell you, in the lungs now, the lungs are too black, so that you can even miss any small opacity. But also, when you can't see the spine through that shadow, you can't see it at all. You see just the shadow of the heart without the spine. That is what we call under penetration. And that time now, the lungs are too white. If there is any small opacity somewhere, you miss it. Okay? Okay? That's number 3 as technical quality. Number 4 is about deep inspiration. Normally, in normal circumstances, normal conditions, you should take the film of the chest in deep inspiration, where the patient has done a deep inspiration, so that you can expose the whole, you can just show the whole lung. You maximize the visibility of the lungs, you know. And again, number 2, things are not distorted. Like when there is no deep inspiration, the heart becomes a bit bigger, which is normal. You can see it cardiomegaly, why it's not cardiomegaly, or even the mediastinum upwards. Now